Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you. And I am not a Chagas disease expert, but I have treated people with Chagas disease not in the HIV setting, but in general infectious disease. And I think a lot of people were surprised by these guidelines and the recommendation for screening, because this is not something that we probably normally do in our practices, in our primary care practice, but something that probably may change your practice. And so we'll discuss that. I don't have any conflicts of interest, and here are the obligatory slides and disclaimers. So just framing it with a case, a 36-year-old man with a new diagnosis of HIV, he immigrated to the U.S. from Mexico 1 year ago, and his CD4 count is 150. He denies any comorbidities. He says he's otherwise healthy, denies any other symptoms. Would you screen him for Chagas? I'm sure many of you have seen immigrants from Latin America in the last few years, or if not more. And is this something that you have been doing? I'm kind of curious.
I see no hands.
Okay. All right. Well, that's a good starting point. Would anyone screen this person for Chagas if you haven't been doing it already, given that we're talking about this topic? Or you're just not sure yet?
Still no hands.
Okay. Well, let's do that same question at the end then. Here's the outline: epidemiology, some clinical manifestations, screening recommendations that are in the OI guidelines, and then just more broadly for primary care, and then preventing disease. I think I could spend a whole hour talking about Chagas, so I'm going to really hit the highlights of what maybe might be helpful to know and frame a little bit of the rationale for screening in people with HIV. So just some general information: Chagas disease is caused by a parasite called Trypanosoma cruzi. It's estimated that around 10 million people in the world have Chagas disease, mostly in Latin America. And you can see the dark blue here. This is from a Nature paper looking at, from 2017, looking at where there is human disease and vector data. As you can see, it's mostly in South America, Central America. But you'll see two states here in the US that have also been reported to have disease, and local disease transmission, meaning that it was not acquired elsewhere. And there are multiple routes of transmission of disease, and we'll talk about the main modes of transmission in the next slide. It's generally been reported in more poor rural areas, and there is a risk in people that live in more kind of rural accommodations and huts, adobe, and thatched roofs, where the organism that transmits this disease can get through. And as I mentioned, there has been local transmission in Louisiana, Texas. Cases have been reported. And we might see more with global warming and vector migration to other areas. And you can see there's vector data, not human data, but the vectors actually exist in the southern part of the US. So there is potential for transmission to humans even outside of this Central America, Latin America area. So what about transmission? The primary mode of transmission is actually a bug bites from these kissing bugs that have the name triatomine bugs, but are often referred to as kissing bugs. And that's because they actually have a predilection for attacking the face and biting the face. And so there's often lesions on the cheek and towards the mouth, or even the eye. And I'll talk about that in the next slide. But it can also be transmitted congenitally through blood transfusion. It's been reported, and even organ donation. There has now been more universal screening precautions for T. cruzii in blood and organ since about 2017, I believe. And so that should be less likely so, at least in the US. Oral transmission is also seen, particularly in wild animals that can ingest the infected bugs that carry trypanosomes and then contaminate and then lead to infection. There has also been reports of food contamination with these bugs that lead to human infection with ingestion, although that is less common. I've included the CDC life cycle here, which is always interesting for our parasites, how they exist outside of the human and where the vectors are. And you can see that there's wild animal disease as well, but mainly from this bug here, then the right upper corner, that is the triatomine bug. That's not that small, actually. That's the fingertip there that you can see. So these are visible. These are much bigger than mosquitoes, for instance. So you would know when it's biting you, but often they bite at night when you may be sleeping and not be aware of the infection. So in terms of clinical manifestations, mastigotes, I can't say that, but they actually circulate in the blood. So the trypanosomes are in the blood during acute infection, but usually not diagnosed. People can have sort of a non-specific febrile illness in these endemic regions and may not get diagnosed, and majority don't get diagnosed. Sometimes it can actually bite the conjunctival or near conjunctival area, and you can get something called the Romagnus sign along with that febrile illness that can be characteristic of acute trypanosomiasis. But again, that's not going to be as common as the bugs can bite other areas and infect in other spaces that may not cause this characteristic swelling. That acute infection lasts for about 60 to 90 days after exposure and then resolves. And then you can get this chronic phase of illness that's usually asymptomatic. However, 20 to 30% of these individuals can have actually clinical disease. And the most common clinical disease in the chronic phase is development of cardiomyopathy. So it's a non-ischemic cardiomyopathy. And in fact, in endemic regions, trypanosomiasis is actually thought to be one of the most common causes of non-ischemic cardiomyopathy. It can also cause digestive disease as well, but it's less common. And then what we get concerned about is actually reactivation disease. So most of the chronic phase does not involve active parasitemia with these organisms, but with advanced immunosuppression, you can see resurgence of parasitemia and high levels of parasitemia that can lead to a more secondary sort of acute disease manifestation, usually a meningoencephalitis, but it can also present like a toxoplasma type presentation that should be included on your differential in patients who present with CNS disease from trypanosomiasis or Chagas disease is endemic. It can also result in an acute myocarditis, so not the cardiomyopathy that can be seen more chronically in the chronic phase, but more of an acute presentation from reactivation disease. So what are the screening recommendations? So the screening recommendations in the OI guidelines is actually to screen all individuals who have lived in Mexico, Central, or South America for greater than 6 months. And so that's going to be all of our people that are coming from these endemic regions and establishing care with us. And so you can see that there are some other priorities within this that are not just specific to HIV, but women of reproductive age during their routine care if they come from these endemic regions, because treatment during pregnancy is actually not typically easy because the medications are contraindicated in pregnancy. And so identifying it prior to pregnancy and treating can prevent perinatal transmission. If it's someone that was born to somebody who has confirmed T. krusei infection, you want to screen that person, that child. And of course, if there was evidence of a bite from a triatomine bug, then you'd want to assess that individual as well. Again, living organ donors, they're already undergoing screening. And then there is a recommendation that is carried forward in the OI guidelines as well to screen individuals that are immunocompromised. In particular, prioritize those individuals, which is what led to that OI guideline screening recommendation. What are the goals of screening? Because that's a lot of people that we would potentially screen, right? And that's to identify people with asymptomatic chronic infection or actually occult disease like cardiomyopathy. And then offer counseling regarding transmission. So if they could potentially transmit through blood, for instance, to other individuals. So that's relevant if they are considering donating at a blood center or also considering organ transplant. But then also when we think about maybe people sharing needles and things like that, that you would want to make sure you counsel individuals. And then what would we do with that information? I think, you'd want to consider treatment for prevention of reactivation disease in immunocompromised individuals. And we know that treatment for prevention is more effective when given closer to the initial infection, similar to LTBI. And then also because treatment prior to pregnancy can avoid that perinatal transmission. So particularly for our immunocompromised women who of childbearing age, this may be even more of a priority recommendation than in the general population or in general population of people with HIV. So what is the screening? There's actually no gold standard for diagnosis of T. krusei chronic phase infection. I think that's really important to note. There are a couple of different antibody or serologic tests that are antibodies based on different antigens. PCR is generally not recommended for screening, but helpful for diagnosis if you have a clinical suspicion of more disease, of the person has a Chagas disease, actually, like a cardiomyopathy or a CNS manifestation, then you would get CSF in those individuals. So what's recommended is actually that people get a serologic test and actually confirm that serologic test with another type of antibody assay. That's not always feasible. If you have an indeterminate assay, you should definitely get another assay to test. And there's some controversy around what to do with these indeterminate tests in terms of treatment. Some would argue to treat and some would argue to not treat. So how do we prevent disease? So I mentioned the screening test and how we would manage that, but just to step back a little, if you have patients that are going to visit endemic areas, it's actually to help reduce the risk of them getting Chagas disease or trypanosomiasis. You want to help them know to avoid sleeping outdoors potentially or in buildings constructed of adobe brick or mud or thatch where those bugs can get in. And then I mentioned that we're already screening individuals. So if someone does test positive based on a serologic assay, then what we would do is offer them a course of treatment. There's only 2 FDA-approved treatments in the U.S. for treatment of Chagas disease, and that is benznidazole and nifurtimox. And you would treat if they've had no prior treatment and no evidence of significant cardiomyopathy. Benznidazole is favored as its first line due to better tolerability, but that medication, even though it's FDA approved, it's only available through one company through their special access program, and you have to prescribe it through that access program. And that is available on the CDC website, the resources for accessing benznidazole. Nifurtimox is available through commercial pharmacy now. It used to not be available for use through that, and it used to only be available through expanded access program through the CDC. Neither of these are of use during pregnancy as they're contraindicated, and there are some drug-drug interactions to be mindful of. Again, if somebody has potential disease, you'd want to assess for that prior to treatment, particularly cardiomyopathy, and so assessing them for any cardiomyopathy symptoms is really important prior to initiation of therapy. Should we screen everyone from Latin America for Chagas? Based on what I've told you, these recommendations, I will point out, are a B3 recommendation. So again, it's not A, meaning we should be doing it for everyone. It is a hard recommendation. B is, yeah, we should do it, but it's not one of those grade A recommendations we would hang our hat on. So it's kind of in between. C, just for reference, is like expert opinion, sort of. recommendation. And a lot of people don't know what to do with C-level recommendations in general. But as a comparison, the anal cancer screening guidelines are B-level recommendations, just so you know. The 3 indicates the level of evidence. And so the level of evidence is low, meaning we don't have randomized controlled trials. We have a lot of observational data to support these recommendations, but it's not a high level of evidence to support it. So, and then, our screening test, like I mentioned, we can treat with benznidazole and nifurtimox. The indeterminate is an area of controversy for sure, because a lot of tests can come back indeterminate because these assays are not great. And there is not a consensus about how to manage these indeterminate results. Some experts would say definitely treat, and some would argue that the risks of therapy versus the potential benefits really don't justify the use of these medications, as the benefits are really unknown. I think there's going to be more data around this as people start to do this more. I asked somebody in the clinic if they've been doing this regularly, and someone has adopted this recommendation and so far have had all negative results. So no one's had a positive antibody that they've had to face treatment decision. It sounds like none of you in the echo community have screened. And so if you do start screening, I'm wondering if you are going to get any positive results.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.